Welcome back, everyone. Today we are diving into one of my favorite bones in the human body. And no, it's not the humerus, despite the bad jokes. We're talking about the clavicle. It's the only horizontal long bone in the body, and it's essentially the bridge that keeps our arms from just collapsing onto our chests. Dr. Sarah, are you ready to unlock the secrets of the little key?
I certainly am, Dr. Khan, and you hit the nail on the head with the name. Clavicula is Latin for little key. While it might look like a simple S-shaped bar, it is functionally sophisticated. For the boards, remember that the clavicle is the very first bone in the human body to begin ossification. It is the sole bony attachment between the upper limb and the axial skeleton through the sternoclavicular joint.
I love that. Think of it like a strut on a high-performance aircraft or an outrigger on a canoe. Without that strut, the pectoralis major and other powerful adductors would just pull your shoulder medially. It holds the arm laterally so it can swing freely. But because it's this solitary strut that transmits all the force from the arm to the trunk, it takes a lot of abuse. Why does this matter clinically? Well, it's the most commonly fractured bone in the body.
Exactly. And when examiners ask about those fractures, they are looking for a very specific location. High yields fact alert. The most common site of a clavicular fracture is the junction of the middle and lateral thirds. This is the weakest point of the bone. Dr. Khan, why don't you describe what a student would see when a patient walks into the ER with this injury?
It's a classic doorway diagnosis. You'll see a patient, often an athlete who fell on their shoulder, or someone who had a fouche, that's a fall on an outstretched hand. They'll be sitting there, leaning toward the injured side, supporting their heavy, drooping arm with their good hand. It's like a crane where the main support cable has snapped. The shoulder looks sunken and moved forward. But Sarah, what's happening internally? The displacement isn't random. It's a tug of war between muscles.
That is a perfect lead-in. This is a favorite board question. Which muscles cause the characteristic displacement in a mid-shaft clavicle fracture? The medial fragment is tilted upward because the sternocleidomastoid muscle is no longer opposed by the weight of the arm. Meanwhile, the lateral fragment drops significantly due to the weight of the limb, and the pectoralis major pulls that lateral piece medially and forward. It's a complete collapse of the strut mechanism.
It really is a mess in there. I always tell my students to imagine the clavicle as a copper pipe. If you bend a pipe, it usually kinks and snaps where the curve is sharpest. That junction of the middle and outer thirds is where the bone changes its curvature. But why does this matter clinically beyond just a broken bone? We have to think about the neighbors living right under that pipe.
You're referring to the neurovascular structures. This is where precision is vital. The clavicle sits right above the first rib, creating a narrow interval. Hidden just beneath it are the trunks of the brachial plexus and the subclavian vessels. While the subclavius muscle acts as a small cushion, a severe fracture or even a massive callus formation during healing can compress these structures. This can lead to thoracic outlet syndrome symptoms, numbness, tingling, or even vascular compromise.
Right, and don't forget the supraclavicular nerves. They literally drape over the bone. If a patient has a fracture and develops persistent pain along the side of the neck even after the bone heals, it might be those nerves getting trapped in the healing callus. If you want to be the doctor of choice for your ortho attending, you don't just look at the x-ray of the bone. You check the pulse at the wrist and test the skin sensation of the arm to make sure those neighbors are okay.
A very important clinical pearl. To follow up on that, let's talk about the surface anatomy. Because the clavicle is subcutaneous and palpable along its entire length, it's very easy to identify these issues through simple inspection. You'll often see a step-off deformity where the bone ends are overlapping. Dr. Khan, you mentioned the fouche mechanism. Can you explain why the force travels all the way to the clavicle instead of just breaking the wrist?
Think of it like a series of connected pipes. When you hit the ground with your hand, the force travels up the radius and ulna, through the humerus, into the scapula, and finally it hits the clavicle, the sole bony link to the chest. The clavicle is like the fuse in an electrical circuit. It's designed to be the point of failure to protect the more vital structures, like the rib cage or the head of the humerus. It's a sacrificial strut.
That's a brilliant analogy. For the students, just remember sacrificial strut equals clavicle. Also, be aware of the ligaments. The coracoid and trapezoid ligaments, together known as the coracoclavicular ligament, are the heavy hitters that anchor the lateral clavicle to the scapula. If those stay intact during a fracture, the displacement might not be as severe. If they tear, you're looking at a much more unstable shoulder girdle.
So, to wrap this up, why does this matter clinically? Because the clavicle isn't just a collarbone for hanging a necklace. It's a dynamic mechanical strut that preserves our range of motion. When it breaks, the whole architecture of the upper limb shifts. You have to understand the muscle pulls, SCM pulling up, pec major pulling in, to understand why the patient looks the way they do.
And from an academic standpoint, remember,
First bone to ossify, weakest at the middle and lateral third junction, and always check for underlying damage to the brachial plexus or subclavian artery. Those are the facts that will save you on exam day and in the clinic. Well said, Dr. Sarah. The little key truly does unlock our understanding of the whole upper limb. Thanks for joining me for this deep dive.